Nice to meet you all. Good afternoon. My name is Dr. Dharmesh Patel. I'm a cardiologist, a practicing cardiologist. I think I'm like you. I see 30 to 40 people every day. I treat heart disease. As what Dr. Perko said, I don't treat populations. I actually treat patients one by one. And this is why I'm here today, ladies and gentlemen. I have a passion about heart disease. I feel that if I do the right thing for my patients, I can prevent events. And why do I say that? This is a poignant point. Tim Russert, a presenter for Meet the Press, died at the age of 58 while recording. And the point of the matter was, he had, quote, asymptomatic heart disease. His doctor said he was well controlled, he was on medications, he had exercise, and he did very well on a stress test. That's well and good, but then why did he die? Why do 40% of patients who have heart attacks die suddenly with no symptoms? 1 in 3 people in America die of heart disease. It accounts for the next 10 causes of cancer put together. In fact, 1 in 3 women die of heart disease. 1 in 33 women die of breast cancer. It costs this country $57 million per hour in cardiovascular disease as it stands. I believe that heart disease is predominantly preventable. I'll repeat that again for you, ladies and gentlemen. I do believe that heart disease is primarily preventable. It is not a cancer. It is something, if you have the right tools, you can prevent events. Think about the staggering facts in our female population. 50% of females who present with heart disease present atypically. There is no such thing as a, quote, typical symptom for heart disease in women. Clearly defined by the Duke criteria and Duke trials, there is no real symptom. I've had 34-year-old cheerleading teachers come into my office with chest pains. They have a slight chest pain and a very mildly abnormal EKG. I said, you know what, let's do an echocardiogram and just make sure your heart function is normal. Lo and behold, the anterior wall is not working, and I still can't believe it. So I call up my colleagues in the cath lab. Look, you're going to laugh at me, but this 34-year-old lady, I think she's having a heart attack. Yes, he starts laughing, of course. She gets a cardiac cath within 1 hour, and the LAD is completely down. It's a very, very humbling disease process. The point is, it only takes a stroke or a heart attack for you to realize the implications both financially, socio-economically, for that patient, and more importantly for the family. It costs about $1 million in indirect and direct costs over 20 years when a person has a stroke or a heart attack. These are real numbers. And I was thinking to myself, why am I invited to an anti-aging conference? I'll tell you why. Because it's no good if you look great 9 foot under. You've got to be alive to age. So, I want to put a different spin, I think, on heart disease. And I do feel it's very, very difficult to talk about aging without talking about cardiovascular disease, since it is the #1 killer in that subset. Period. So, Tim Russert, he did have all the, quote, right tests. Yes, he had a stress test. So what is a stress test? Well, it's a way of determining if someone has a physiological blockage. That's well and good. But does it truly tell you the vulnerability of that vessel wall to rupture? No. How do I know if I do a cardiac catheterization on you and there's a lesion that's got a 20% stenosis, I say, oh, Mrs. Jones, you are doing wonderfully. You've only got a 20% narrowing. Have a great day. I'll see you back in a year. That's well and good. How do you know that 20% lesion is not a plaque waiting to rupture? And the data proves the point that if you have a stenosis of, let's say, 80%, that is less likely to rupture than a plaque that's of less severity. Ironically, about 78% of patients who have a stenosis less than 70% rupture, and 68% of patients have a stenosis less than 50% that ruptures. So the point I'm trying to make is it doesn't have to be a 90% stenosis for it to have an event. The people that dropped dead, unfortunately, like Tim Russert, had probably a 20 to 30% stenosis, which was an acute, hot plaque with a thin, fibrous wall that suddenly ruptured, unfortunately. So then you're going to say, well, Dr. Patel, that was really good. You kind of sound good and you say a lot of good stuff. But how do you figure out then who's hot and who's not? His doctor went on to say, it changes people's lives. We make them feel better, live longer. Our hopes are not fulfilled. We all struggle with the fact that there are limits to what we can do. I respect my fellow colleague, but I do disagree on some of this information. I practice in a busy practice. I see 50 people a day with a nurse practitioner or two. I tell my patients this. If you listen to what I say, with the tools I have, I truly can hopefully avoid an event. Now, I live in Memphis, okay? It's the lard belt of America. I treat some of the toughest people, I think, in this country. They're very difficult to treat, but you know what? I can tell with my laboratory diagnostic markers which patients are more likely to have an event than someone that's not. We'll come on to how you figure that out later. But I do disagree with this statement. I actually think we have the technology to not only tell us about disease progression, but, quote, its activity. Remember what I told you about a cardiac catheterization. If someone has a cardiac catheterization and the luminogram looks okay, you say, well, you don't have no heart disease. Well, that's absolutely wrong. Because we all know that atherosclerosis starts extra lumen first, and then at the very end stages of atherosclerosis, it encroaches in the lumen. So by the point it's 20 or 30 or 40%, most of the cat's out of the bag. And it's at that point you want to stabilize that plaque so it does not rupture. We now have technology that can tell us not only the likelihood of the circulation causing plaque formation and rupture, we also now have technology that can tell us the vulnerability of a vessel wall in how it's going to rupture. So I would absolutely argue that if Tim Russert had come to see me, that I probably could have told him that he was, quote, hot, and we need to probably do more. Why is it that 50% of patients who have normal cholesterol have cardiovascular events? If it was, quote, that simple, just lowering the LDL below 70 would be great and we could all pat ourselves on the back and have a great day. It's not so simple. When I treat heart disease, I treat it like a jigsaw puzzle. LDL is one facet. How hot or how likely is that patient going to rupture? What about sleep apnea? What about insulin resistance or diabetes? What about weight? What about exercise? And what about genetics? The fact of the matter is 2/3 of patients who have heart disease or a myocardial infarction have insulin resistance. That's a fact. How many cardiologists check for it? Probably about 1 or 2%. How can you treat patients if you're not treating the whole paradigm? How can you treat patients if you're just fixing one problem, not fixing the other 16? That's why I thought I practiced good cardiology about 5 years ago. I'll be quite honest with you. I thought I did. And then with more education, I realized that I was doing a mediocre job. Mediocre. Because I realized that so many of my patients had other risk factors above and beyond the standard of care. And now I'm not going to sit here and say the standard of care is bad. It's absolutely great. But I don't treat populations. I treat patients one by one. And the fact of the matter is, sometimes the guidelines lag current therapies. And that's a fact too. So this is why I'm excited. We practice classic lipid panels, which are long-term risk. There are mid-term risk panels like the advanced lipid testing. And then there's near-term risk, which we can use in terms of inflammatory markers. Atherosclerosis is a chronic inflammatory disease process. This was found many years ago by Dr. Russell Ross in 1976 with his injury hypothesis. But the point of the matter is atherosclerosis is inflammatory in origin, and I'll explain why. Oxidation leads to inflammation. Inflammation leads to plaque formation. Continued inflammation continues to plaque rupture. That's the way it goes. And to that point, we have made strides in big ways in determining how to treat cholesterol and prevent events. In fact, you all know that if you reduce your LDL by 39 points, you reduce the risk of an event by 22%. So we know now that we've had statins for a very long time. I think they're excellent medicines. They not only lower LDL, I do think they have a pleiotropic effect. And as I mentioned earlier, 50% of patients who have had a heart attack or stroke have normal lipids. So that's why I'm excited to talk about markers which I think add to the table in truly defining and risk stratifying our patients, especially the intermediate risk and high risk.